Next up is Hailey MacVicar. Hailey started at StoneCrest Center in 2020, working in the utilization management department and transitioned to the court department in 2022. Haley played an integral part in implementing the Wayne County Probate Court's Behavioral Health Unit's Assisted Outpatient Treatment Program when it was initially piloted at SCC in about mid 2022 and has since worked with numerous other county courts and CMHs throughout the state. In addition to her role as a court liaison and patient advocate, Haley works closely with the rest of the clinical services department, including the social work and utilization management departments, which have given her a unique perspective of the court process and the mental health system in Michigan as a whole. So Haley is also a current graduate student pursuing an MSW at Oakland University. So without further ado, I'll go ahead and kick it over to you, Haley, now. We're going to go ahead and have Devon share your PowerPoint. So whenever you'd like him to advance the slide, just go ahead and say next slide.
Awesome. Thank you. Can you hear me okay?
Yep.
Okay. And please feel free to stop me if someone has their hand raised, because I probably won't see it. But thank you for having me. Like Olivia said, I've been at StoneCrest for a few years now. Kind of going from UM to court, put me in kind of a ideal position to help with implementing these AOT program expansions. I kind of already had these connections and relationships with a lot of our payers and CMHs. But today I just want to give a little overview and insight into the inpatient role within the AOT system, talk about some things that we've learned over the past couple years, and then try and give some suggestions or recommendations for CMHs and everyone else to kind of think about as you're developing your own programs and, learning about the system. Next slide, please. Let me see. So at StoneCrest Center, the role of our court staff is mainly to facilitate the court processes, and especially with involuntary patients when they come through. The court staff will facilitate those hearings and the communications with the attorneys. But more importantly, our job is to make sure that all of our patients' rights are being protected, that they kind of understand what's happening and that what their choices are to the extent that they can. And make sure that they understand kind of what they're going through, especially with that court process. Within the larger system, the hospital kind of acts as the middleman between all of the other parts of the system. We facilitate the communication between all the different outpatient providers and CMHs, and then there's the courts and the attorneys, families and guardians, and then the insurance companies. So we're kind of right in the middle of all of that, especially once the patient's with us. We're doing that communication and then also facilitating the communication between the different parties together. Next slide. When the next slide again, I'm sorry. When the behavioral health unit kind of started expanding their AOT program in Wayne County, it also kind of expanded the role of the hospital in the AOT system as a whole. It kind of expanded upon a lot of our normal processes in the hospital. There was a lot more communication and coordination with the outpatient providers while patients are in the hospital, kind of trying to facilitate that connection engagement with the CMHs and CRISPs while the patient's in the hospital, helping build those relationships with those outpatient providers so that the patients are hopefully more likely to follow up with their outpatient treatment when they discharge. The social work and UM staff here have gotten a lot more involved with the court process, with especially with authorizations and things like that. And we've also gotten involved in a handful of review hearings and discharge planning meetings, which have been really helpful with some of our more complex cases. Our patients with placement issues or more kind of severe comorbid medical and mental health issues, being able to bring in all the different parts of the system, kind of have a meeting, talk together, kind of see what identify some of those barriers for compliance with outpatient treatment, kind of prepare the outpatient provider to receive them in the community, and kind of see what they can do to mediate some of those barriers and hopefully reduce future hospitalizations, but also, facilitate and encourage that continued treatment and healing for the patient in the community. Next slide, please. One of the bigger roles of the hospital within the AOT process is we are responsible for scheduling and facilitating deferral conferences. Um, that goes for any inpatient facility, when someone's hospitalized. This has been something that's been a big a little bit of a shift, a little bit of a learning curve for not just Stonecrest, but I know a lot of the hospitals. For I don't know, the longest time, deferral conferences were typically the attorney calls, they talk to the patient, they decide what they want to do, and then we have court or we don't. But with more and more courts kind of enforcing the part of the mental health code that requires a representative from the CMH to be present, that kind of forced us to kind of review and change some of our processes. And ultimately, I do think it was a good thing. It gives us an opportunity to connect with the CMH and for the CMH to connect with that member while they're inpatient. But at the same time, it can be quite a challenge trying to get all of the different parties at the same place in the same time within the time frames that are, required. So when a petition's filed, we are supposed to have the deferral conference within 72 hours after that petition's filed, which in practice doesn't necessarily always happen because we have to wait until the court gives us the paperwork and we serve the patient. Um, and then the deferral conference also needs to happen at least 24 hours before that hearing. And then on top of that, we try to give our, CRISPs and CMHs at least 24-hour notice, so that they can have time to prepare and attend that deferral conference. I have to really give a shout out and thanks to our CRISPs and all our other CMHs who have been so patient and kind and working with us as we kind of navigate this and get used to these different processes. A lot of times we're kind of at the mercy of the attorneys and their schedules, as much as we try to educate the attorneys and the different groups that of the importance of having the CMH there and that's, actually being an enforced requirement now. Some of the attorneys aren't always don't have the most readiness to engage in those process changes. So that's been kind of difficult to challenge at some times, or difficult, to kind of manage at times. But I also really appreciate I know a lot of the CRIS and CMHs and BHU and DUN have all been kind of trying to work on educating those attorneys too, so that they can kind of understand the importance of that and, the why that's important for the CMH to be there. Um, and so then also the hearing happens usually within 7 days after the petition's filed. So there's a lot of things that need to happen in a very short time frame, which in a lot of ways is good. Mental health court is probably one of the faster courts. Things happen a lot faster than any other court, which makes sense because we need to be able to treat people while they're inpatient. But it also kind of puts a lot of some restrictions around what we're actually able to do in practice. On the other side of that, we're trying to find a time and fit into everyone's schedule a time that works for, not just the patient and the hospital and the attorney, but also, someone from the CMH or the CRISP. A lot of times, if someone has a guardian, they want to be involved. I've had deferral conferences where we'll have the PO or the probation officer, and then patients also have the right to have um, someone of their choosing attend, which doesn't happen often. But if a patient says, "Hey, I want my mom there, I want my sister there," that's something that we try to accommodate too. So a lot of moving parts, a lot of people needing to be in one place at one time, which can be challenging, but It has been an adjustment. It's something that kind of we're still working on. But again, I appreciate everyone and working with us as we kind of get through that. Um, okay. Next slide. So in the past couple years, we have definitely learned a lot about the, AOT process and kind of some of the things that go into court orders. I know one of the things that we've talked about a lot in these meetings is that every court, every judge, and every county does things differently. That was something that came as kind of a surprise to me. You would think that since most of the processes are based on the mental health code and, these different laws, that they would be pretty straightforward. But we've learned is that every judge seems to have a slightly different interpretation of the mental health code and also different ways that they enforce that. Next slide. In summer 2023, Wayne County stopped facilitating courtesy hearings. So when we have patients from outside of Wayne County would facilitate those mental health hearings aside from some of our, larger counties in Southeast Michigan. So during that time, I think it's kind of also forced a lot of other courts within the state to review and revisit their own processes for mental health, kind of relearn how to do those things. And since then, since about July 2023, as of yesterday, we've filed petitions in 61 different counties, and we've had hearings in 46 counties. Next week, I think that'll go to 48. So it's definitely been interesting. A lot of different judges, a lot of different people involved, and so that's kind of been challenging for the hospital, and I'm sure just as challenging for the different CMHs, as things differ from county to county, and court to court. It can be kind of difficult to try and anticipate, which pieces are going to be enforced or which pieces are going to be prioritized. But ultimately, it seems like more and more judges are really trying to focus on having the outpatient engagement piece happen during that inpatient hospitalization to kind of facilitate that engagement and follow up with the outpatient treatment. Next slide, please. Um, okay, so one of the other things, oh, I think I missed it. Can you go back one? I'm sorry. So kind of one of the other things that we've ran into is we've noticed a lot of issues with enforceability when it comes to court orders and assisted outpatient treatment. A lot of parts of the mental health code kind of contradict with one another. And a lot of the things it sounds good on paper, but in practice, we know it doesn't really always pan out with how our actual systems and processes work. For example, we've talked about how most CMHs can't offer ACT services when someone lives in supervised living. So if a court order has both of those checked, it's kind of, what do you do there? Another thing that we've kind of noticed is that, some of the check boxes on the court order, like supervised living or SUD treatment, can't realistically be enforced in the community. Um, Most AFC homes won't accept a patient for placement if they're not willing to go there. Even if they have a guardian, even if the court order says supervised living, if it was as easy as having supervised living on a court order to get a patient placement in an AFC home, nobody would have placement issues, right? So a lot of what I've seen a lot of courts do now is add in language that'll say referral for supervised living or, an evaluation for SUD treatment. And I think that kind of is a little bit more realistic, especially with enforcement and just with the services that are realistically available in most counties. Kind of on that same line with, in the hospital, we are able to give medications via injection, and kind of enforce that medication compliance. But most outpatient providers and CMHs, if a patient comes into the clinic for their medications or their injection and they're refusing, they're not going to force that medication. So there's just kind of some parts there where it's, just because it's on the court order doesn't mean it can always be enforced. And on the other side of that, there are just unfortunately some consumers, some patients who are just not going to follow up with treatment. I've talked to some CMHs who will say, we called them on this day, we went to their house, we offered them this, this, and this, and we just cannot get in contact with them. And I definitely appreciate the amount of effort that the CMHs have. Put into, especially with all of their patients, but patients with AOTs, absorbing that responsibility for monitoring that patient, and doing what they can. Um, Another thing that we've kind of noticed is especially with the mental health code, in a lot of ways, it kind of is self-contradictory. It doesn't always account for all circumstances or any special circumstances that come up. And especially in the inpatient setting, the mental health code doesn't really take into consideration medical necessity, right? So at StoneCrest Center, but also all inpatient facilities, um, it's an acute care facility, right? So patients come to us when they are in crisis. Um, they Our main treatment goals is stabilization. Someone comes during that psychiatric event or episode, dealing with those emergent symptoms, immediate symptoms, and their presentation, and then also getting them to a point where they're stable enough and safe enough to facilitate, that safe transition back into the community. But we all know that real treatment and healing happens over a longer period of time in that outpatient setting. An average length of stay at Stonecrest is around 10 to 14 days. A lot of hospitals, it's closer to 7 to 10 days. So it's really a very short time frame to kind of address all of the different things that are outlined in the mental health code, while also trying to make sure that the patient is at the lowest level of care needed for their presentation. Um, Once a patient is at a point where they no longer meet that criteria to warrant the inpatient level of care, they're expected to be discharged back into the community. But that doesn't necessarily mean that they no longer require mental health treatment or that they would benefit from continued hospitalization. In a lot of cases, even though the patient doesn't need hospitalization anymore in that moment, they're stable and not in crisis, they would still benefit from a court order or an AOT, especially the patients who have had repeated hospitalizations or we know they have a history of noncompliance with medication and outpatient treatment. Um, in my experience, most courts will dismiss a petition if the patient is not still hospitalized on that hearing date. So even though the patient might not meet criteria for hospitalization any longer, they need to remain in the hospital until that hearing date for the court order to be granted. This is something that a lot of insurance companies don't understand. The CMHs definitely have a better understanding of that than a lot of private insurance companies. But in most cases, waiting for a court hearing doesn't warrant medical necessity. Um, Next slide, please. So going off of that, something that CMHs and providers can do to kind of mitigate this is take kind of a proactive approach to utilizing that hospitalization period, that time when you know where the person is, where you can get in contact with them, and initiate that court process when the patients are first hospitalized. When patients are inpatient, most petitions are initiated by the hospital, but that doesn't mean that the CMH can't file that petition. If there's a consumer who would benefit from an AOT, and they're hospitalized, reach out to that hospital to see if there's anything you can do to help get that process started. the patient will be there for a couple of weeks. It's an easy way to make sure that they're getting served with the paperwork, have the time to meet with their attorney and all that. Um, for patients who are admitted on deferral commitments, as soon as you're aware that the patient is being admitted to the inpatient hospital, file that demand for hearing and get that process started. A lot of times, you know, with that, a lot of times patients will come into the hospital with the CMH already having completed a petition or filled out the demand. But the paperwork will come in a huge stack of documents. A lot of them are relevant from the emergency room. And the hospital really has no way of knowing whether or not that demand was actually filed with the court. And in most cases, it wasn't. A lot of, especially with the emergency rooms, they'll fill out the petition, send them, and that's about it. Um, and so by the time the hospital's aware that a demand is even needed or that the person came in on a deferral, 4 or 5 days have passed before we can even start that court process, which then translates to a longer length of stay for the patient. So when we can start that court process early, it can hopefully lead to a slightly shorter length of stay for the patient, a quicker transition back into that outpatient treatment, and then kind of lower that cost on the county, both financially and in terms of utilizing those county resources and also the super limited beds that there are in inpatient facilities. Um, on that same train of thought for CMHs, please um, think about notifying the hospitals when your patients are admitted on active court orders. As we know, there's no centralized database for tracking and monitoring mental health court orders. So in the same way as deferrals, we don't always know that patients are on court orders when they're first admitted. A lot of counties have different databases for different things, but they're not always accurate or reliable. So again, when you're aware that someone's being admitted on that court order, letting the hospital know. So again, we can start that treatment faster, get that process going, and get them discharged. Um, kind of, let me see. Um, um, with the addition of having CMHs in the deferral conferences, I definitely recommend identifying that person at your CMH ahead of time who would be the one to attend those deferral conferences, and kind of communicate that information to the other departments in within your organization who communicate with the hospitals regularly, like the Access Center or your team, especially if the CMH is the payer for that hospitalization. Um, the staff would be are already likely in pretty frequent communication with the hospital, and can kind of help facilitate that communication and that connection with the CMH staff who would be attending that deferral conference. And then also for especially for some of our a lot of the crisps have been doing this with having a specific email address just for AOT and court related communications, just to kind of help the hospital with knowing who to contact and who to reach out to for those deferral conferences, especially when we are in those kind of really limited time frames, would be definitely helpful for the hospitals. And then as far as your the CMH attendance during the deferral conferences, um, I think looking at it as more of an opportunity to engage with that consumer versus, a requirement because the mental health code says you have to be there, and checking a box. It's utilize that deferral conference and that hospitalization overall, to your advantage, since that consumer has to be in or is going to be in that place and you know where they are, you know, use that opportunity to engage or re-engage with the patient. Kind of start building that rapport. I know it's hard for CMHs to kind of start those intakes or start meeting with those patients when the patient's inpatient, because we can't bill for both inpatient and outpatient services at the same time. But especially for in an ideal world, if I could have CMHs come in and start those intake assessments while the patient's in the hospital, I think it could help with following up on an outpatient level. The patient can get to know the people that they're going to be working with, talking to. You know, Kind of the downside of that is a lot of times when deferral conferences happen, they're towards the beginning of the hospitalization, and a lot of times the patients aren't necessarily a in a mindset or a place where they can really effectively communicate or engage in discharge planning. So sometimes that might be a conversation that makes a little bit more sense to happen later in the hospitalization. And with that, I'd recommend kind of communicating with the hospital staff, the social workers, and the UM staff to kind of figure out, when a better time frame might be to try and engage with that patient. Allison, yes.
And then I forgot where to find my microphone. Hey, and thank you for this. And before I forget, can I get a copy of your slideshow here?
Yeah,
Of your
for sure.
presentation? Awesome. But I did want to just throw out there, from the DON standpoint, I'm gonna put it out there for everybody. If the person is actively engaged with their CRISP, or I should say, if they at least have, if they're open with them. So if they've actually been there within, say, like the last year, the provider can meet with them at the hospital and bill it for targeted case management for discharge planning. So I know that has been a source of confusion between duplicate services. But from our end, we actually encourage that. We would love for our providers to go out there and actually see their people and be involved in the discharge planning. So I just wanted to throw that out there. Thank you.
Yeah, no, for sure. And we definitely encourage that on the hospital side. Like I said, I definitely recommend kind of reaching out to the hospital ahead of time, especially when you're coming in person to meet with the patient. Like I said, a lot of times the patients aren't stable yet, and it might not be, the most effective use of your time as a CMH, but also for the patient, not being able to really engage in kind of a fruitful conversation about their needs and some things that they might be interested in as far as outpatient treatment. Um, Again, I
Correct.
know a lot of providers and agencies push that visit within the first few days of the hospitalization. But that's something that I might think about kind of revisiting as an agency, just as in terms of, you know, limited resources, limited people, if we are kind of taking that time to engage with those consumers, doing it in the way that might be the most efficient.
For everybody. Good point. Good point. And
Yeah.
even if they're still maybe not the most aware of everything or the most stable of, let's get down to business and plan this, this, and this. The one thing that would stick with the member is you came to see them.
Mhm.
Just trying to begin that re-engagement or developing increased rapport with them. That's the part they are going to remember. They might not remember, hey, well, remember we talked about coping skills and we talked about this, but they will remember that somebody cared enough to come and actually visit them.
Mhm.
So that right there, I think that's the most important part of that coordination.
For sure. And, I think about myself, I wouldn't necessarily want to, especially if I was just in a hospital for a couple weeks, going and trying to talk to someone who I've never met, I've never seen before, and tell them about probably the worst time of my life. Could be pretty intimidating. you know. With the deferral conferences too, a lot of I've noticed that a lot of attorneys may not, although they're working on the, mental health docket, they may not have had very much experience working with people with severe mental illness, people with, psychosis and delusions. So on as the provider on the CMH side, I definitely empower you to speak up in those deferral conferences. A lot of times it kind of seems like the attorney is running the show. And while they do need to get their spiel out, talk to the patient, go for it. And, kind of talk to the attorney too, if you need to. I've seen attorneys try to challenge patients' delusions during deferral conferences, which, we is not ever effective and just kind of agitates the patient. So as the clinician and as the person with more experience, working with those consumers, especially if it's your client, someone you're familiar with, even though it's an attorney, it can be kind of intimidating. Um, you're there for a reason. You can speak up and engage with that consumer. On the hospital side, that's something that we try to do as well. We do a lot of translating the attorneys speak into something that the patients can kind of understand a little bit more. We're speaking with them before and after the deferral conference. We can't give legal advice, but we try to explain those different options and those different processes in a way that might be easier for that patient to understand. And also too, we use the deferral conference as a way to kind of talk about not only what the hospital and the treatment team's recommendations are, but kind of get an idea of what that consumer might want from outpatient treatment. Um, for a lot of patients who are resistant to treatment or therapy or medications, we try to identify something that they would be interested in, figure out what their needs are. A lot of patients talk about housing, or they need a new phone, or they need some help with their bills. And we let them know that those are all things that your case manager can help with too. Try and identify some things that would motivate them to follow up, even if it is something smaller, like helping me get my SSI turned back on, those kind of things. So it doesn't always have to be necessarily one of those check boxes on the AOT, even though those are services that we would recommend. I don't think I've had many patients who I'd say wouldn't benefit from interpersonal therapy. But if that kind of anxiety around, following up with a, mental health provider, is there and kind of might, I don't know, hold them back from getting services, kind of trying to find something that might motivate them to follow up and engage. And then, if they're coming in the office and even meeting them kind of where they're at, as you build that relationship with them, you can try and engage them or encourage them to incorporate other services and things like that into their treatment plan. But yeah, definitely utilizing that deferral conference when it's appropriate and when you're able. Like I said, a lot of times patients aren't interested in engaging in those conversations at that time. But again, kind of like Allison said, even making that connection with that person, letting them know that there's someone out there who's kind of looking out for them, wanting them to get better, and help them get the things that they need, can make a big difference for a patient, especially when you're inpatient. You're losing a lot of your own autonomy. We want to try and have people be engaged and participate in their own treatment as much as they can. And again, they're a lot more likely to engage in their outpatient treatment when they are able to kind of have some kind of agency in that treatment planning. Yes, Clarissa.
Hi. So you mentioned this earlier about sometimes it seems like during the deferral conferences that the attorney kind of runs the show, or has their little spiel. So that's a problem that I've had, is like feeling like it's important for me to preserve the relationship that I have with the attorney. And sometimes this particular attorney that I work with um can be rubbed the wrong way, or take things personally if I want to jump in or say something. It seems like I don't really have a place to do that, but lately over time, as I've been developing the relationship with him and attending more of the conferences, I've kind of gained more confidence to start talking more in the conferences, which is really good. But I wondered if, um, well, I know you mentioned some of it already, like certain things to talk about, but like, what do you think is a really great way to introduce ourselves, in a way that is like helpful for them, but also not seen as like challenging to the attorney, if that makes sense? Like the best way to introduce, why we're there, how we can help, and or like maybe certain things are there things we shouldn't talk about or mention? That's kind of where I'm going with that.
Yeah. No, I know what you mean. I know a lot of, especially for some smaller counties where there's only really a few attorneys working on those mental health dockets. In a lot of ways, that can probably be a positive thing because you can build those relationships with those attorneys. But also sometimes, attorneys are gonna attorney and kind of do their thing. Something that I've seen some of the other CMHs do is, especially for when you're kind of noticing that that patient's more resistant to the conversation overall. You know, Sometimes starting out with just introducing yourself and kind of trying to let them know that you're not necessarily there for the legal side of it. You're there as part of their treatment team. You're kind of on their side. Even though the attorney is there to represent them, a lot of patients, when you hear court, when you hear attorney, it can feel kind of combative. Um, so for being on the CMH side, especially when it's a consumer that you're not really familiar with, I don't know, I kind of try to put it as if I was that patient, if someone was coming to me and being a stranger and kind of reaching out. I think a lot of ways connecting with them is a way to kind of connect with the patient, and also, with that attorney, is being that patient's advocate and kind of showing that you're on their side. Um, a lot of times, if a patient is not really interested in engaging in those conversations, it can be challenging. Um, and kind of too, one of the other recommendations that I had for the CMHs in general is, um, especially for some of the smaller counties, reach out to the CMHs in the adjacent counties. I have seen more and more where the county where the patient's court order is may not necessarily be the county where they've been receiving services, either because they moved or went back and forth between counties and things like that. Um, so kind of building those relationships with those CMHs around you, but also kind of getting an idea of their processes can kind of um, kind of seeing what they're doing, how they address some of those things, especially if you have some of the same attorneys, kind of see, what some of the other people, CMHs are doing too. I know it's hard when, especially in Wayne County, we have probably 20-ish different attorneys, that we'll work with on any given day. So it can really, vary there.
Okay, yeah, that is helpful. And I wondered if you had any insight, because, well, more specific to me, like one of the barriers that I have is, so it's really this one particular attorney that I do the deferral conferences with, and he only has like Zoom meetings, for like a certain amount of time. Like I think it's like 45 minutes or something like that. So like there's not a whole lot of time, and sometimes we'll do like 3 conferences. And so there's not, so is there a way, like, I don't know if you have any useful tips or anyone else on the call, like, not necessarily to the Zoom like time restraints, but more so like how to have a conversation with the attorney about like maybe restructuring the way that the deferral conference is going to be helpful to the person. Because for me, he says a very cookie cutter spiel and goes very quickly. So there's not a lot of space for me to jump in unless I really, jump in at the right moment before things start, going too fast. So I'm looking for helpful tips on that, like having conversations with the attorneys about that.
We see that a lot. The attorneys kind of move really fast, maybe, 4 or 5 minutes in and out. In the cases where we only have one patient seeing the attorney at the time, sometimes we'll have the attorney just kind of do their thing, get that through. And I'll tell them that they can leave, honestly, and then continue having that conversation with just like the CMH, and that provider, and hopefully kind of go through that conversation. It's not always the most effective because the idea is to discuss the treatment plan and the recommendations and the possible outpatient services with the patient before they're signing that deferral or that stipulation. But it's not, I kind of also go back to needing to meet the patient where they're at. And when we're in that situation where the attorney is not really wanting to or having the time to engage in the treatment planning side of it, I guess I prioritize having that conversation with the patient at all. Really. So sometimes, I guess this would probably come down to the hospital that you're working with or that liaison at that hospital to be able to kind of facilitate that. But yeah, sometimes I will kind of tell the attorneys that, okay, well, thanks, Joe, we can take it from here, kind of thing, which especially for attorneys that might be come across as a little bit more aggressive or confrontational, sometimes just removing them from that conversation can make the patient feel a little bit more comfortable too.
That is a good idea because I wonder, I know that it's him that he's the one who hosts the meeting, so he couldn't necessarily like not like couldn't leave us alone in the
Mhm.
meeting, but I wonder about me coordinating with then, those liaisons after the fact. I mean, like, hey, can we collaborate about this patient and, figure that out. So that's a good idea. That's really helpful. Thank you.
Yeah. We'll do that too sometimes, especially for patients who, at the time of the deferral conference aren't really engaging. We'll try and circle back with that CMH and see if even, later in the day or a different day they want to connect with them. Again, that it is kind of a double-edged sword just because it does put that extra kind of time and burden on both the CMH and the hospital. And it kind of comes down to that hospital liaison's ability to have that second meeting or that additional meeting. But that's kind of one of those things too, where coordinating with your person at the CMH who is talking to the hospital, maybe being able to connect with that social worker too. At least at StoneCrest Center, it's usually the court liaisons who are facilitating those deferral conferences. But the social workers are the ones who are really spending the most of the time with the patient in their discharge planning. So sometimes kind of reaching out through those means might be helpful too, especially since your reviewers are usually talking to the hospital every couple of days, and might be able to help pass along information both ways and also kind of get you in contact with, if not the social worker, then the court liaison at those hospitals.
Yeah. Thank you.
I want to jump in really quickly here, because Michael has a question in the chat, and then we can pop over to Nadia. But Michael says, "Thank you so much for the presentation. Who should be notified of a court order at StoneCrest, and can we get that contact information?"
Yeah, I can throw that in the chat. At StoneCrest, our court email or contact is _StoneCrest court process at stonecrestcenter.com, the world's longest email address. For yeah, for other hospitals too. Again, if your person is aware that they're on that court order, to communicating that to whoever is doing the reviews at the hospital can hopefully that information kind of trickle down. Yeah. It's _StoneCrest court process at stonecrestcenter.com.
Lovely. Thank you so much for sharing that. I appreciate that. Now we can kick it over to Nadia.
Hi, Haley. I was just gonna go off kind of what Clarissa was saying. I have noticed that the attorneys, and like I said, it really depends on the attorney, but yeah, they are often moving very quickly and they don't usually ask like kind of any recommendations from the CRIS, which in some ways makes sense because they're there for the person and what they wish. But I've also noticed at the court hearings, the court also won't ask for like any feedback from the CRIS pretty often. So I'm wondering when the CRIS are very familiar with their person, or at least reasonably familiar, who would it be best to kind of feed those recommendations to? Like, would it be better to feed them to like Stonecrest or Pontiac General specifically? That way, when the psychiatrist actually presents at court, they can say, hey, we think it'd be a cool, well, not a cool, but a great idea for this person to also have A, B, and C because we know based on history that they have whatever concern. Would that really be the best way to kind of get that in the order?
I would probably go reach out to the hospital, either, that court liaison or identify if you're able to identify the social worker who's working on that case,
Mhm.
with those treatment recommendations, not only for the AOT, but also just so the hospital team is kind of aware when they're guiding that treatment. Um, and then so then in that hearing, the psychiatrist or psychologist who is testifying can give those recommendations. I know most CMHs are filling out that ATR before the or before the hearing with your treatment recommendations, but the hospital doesn't usually get those ATRs. So, the psychologist and the testifying psychiatrist aren't seeing those recommendations. We do get them from some CMHs and a lot of times the clinicians who are completing them will send them to us. But as general practice, we're not consistently getting those. So yeah, I think reaching out to especially the social worker who's on that case to kind of communicate that would probably be the easiest. I know a lot of times, especially with hospitals, calling back and forth, playing phone tag isn't always the most efficient. I always recommend email, especially because we can just forward it on to the other people and on to the doctors with that.
And who is sending out the ATR? Because I actually don't know that I've ever seen the ATR. Is it in that initial kind of giant email that BHU sends out? Or
For
where does
Wayne
it come
County,
from? Mhm.
I have no idea, to be
Okay, I've
honest.
never seen it either. That makes me feel better. Okay, what
Yeah.
does ATR stand for? And I'm gonna go figure that out. It's okay if you
Um,
don't know that either, because I can Google.
Nadia, it's
Mhm.
Christy. It's
Hi,
I'll
Christy.
hello, Nadia. It's alternative treatment report, and the probate court should be putting that in the packet when they send you the notice of hearing.
Okay, I don't think I've ever seen that in there, so thank you very much. I will follow up on that because I know some of our Chris would be like thrilled to be able to just stick it in there and get it to the hospital. So thank you very much, Christy and Haley.
I wanted to bring attention to something Megan Hebert from OCCHN said. She said our monitor attempts to hop on a deferral early if possible to try and just build some rapport with the attorney. And if we have that time, also we'll try and let the attorney and the court liaison let them know what is going on with the individual if we have some important info. So thank you so much for that addition, Megan. I know we're approaching at the last couple minutes here, so I wanted to hopefully answer a straightforward question, which is a follow-up. Can the StoneCrest email accept encrypted emails via Microsoft 365 encryption? Do you know, Haley?
It really depends on your system that's sending it to us. We can usually open most encrypted emails. Sometimes they come through kind of wonky. On the other side of that, I know we usually try to send most of our communications through secure email. But I get a lot of feedback that, the CMHs or the external places can't open the emails. But I mean, definitely try it. And if we can't open it, we'll let you know and hopefully try and get that information in a different way.
Copy that. Thank you so much. Does anybody have any final thoughts or maybe a quick question we can get in this last 2 minutes here?
I'll say just one thing. I know that we have spoken with hopefully you guys can hear me because I should have put on my other headphone. We have spoken with our court register, and our plan is to try and attend the next attorney training to kind of get some insight to the attorneys on, why we're doing this, what our goal is, just to kind of build that rapport and let them know, like, we're not here to make it more difficult, which I think sometimes they feel that way. It's really to make your job easier in hopes that if we can connect with this person, they won't end up back in the hospital. So if we can all work together. So I know, that's one thing that we are really pushing is to try and make that happen. So we can get hopefully in front of them so they can see our faces and just really get more information out there.
Love that. Thank you, Megan. Appreciate that. I know that our team had visited a attorney training in Washtenaw very recently, and that proved to be very fruitful. So that's a great suggestion and a great move forward. But yeah, we'll go ahead and end it here. Thank you so much for making this an extremely robust space for learning and education. Thank you so much, Hailey, for this presentation. This was great. If you have any lingering thoughts or questions, you can reach out to me. As always, I will communicate the slide deck and the focus group flyers in which I presented earlier in a follow-up email on Monday. Otherwise, we'll see you all next time, Friday, November 22nd at 11 a.m. and have a great weekend.